right, welcome in everyone. Just going to get our presentation up here for our open close slides. All right, I want to check with everyone. You can see our presentation this morning. Just a quick thumbs up is good for those of you who have your cameras on. Perfect. All right. Our presentation today is working with pregnant and parenting people who use drugs. Our presentation is being brought to you today or being hosted today by UW-Madison Division of Extension and Michigan State University Extension. So we want to thank both of our host universities for bringing the presentation today. My name is Amanda Cara. I am the Technical Center's Regional Project Manager. Glad to see everyone today, even though I can't technically see you. And we know that you're all there and we're glad that you signed up to be part of our presentation today. We have a couple of housekeeping items that we need to go through. If you've been with us before, you're familiar with it. If this is your first time, well, welcome on in. The first is to just go through our funding acknowledgement, and that is that we are a Great Lakes ROTA-RC funded project through SAMHSA. This project is a training and technical assistance project. We serve the rural communities of Health and Human Services Region 5, which covers Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. If you come from outside of that region, you're welcome here as well. We're happy to have you. It's just that we cover those areas specifically as far as our technical assistance. If you want to learn more about us, you can go to our website. We'll be putting that up later towards the end of our training, so don't worry, you don't have to quick capture it here. We'll be putting that up into the chat. As far as our website, this is just a quick look at a little bit of what we offer on our website. As far as virtual education, we do have a newsletter. We also have toolkits and resources available. In our newsletter, we provide news and updates that link back to our website. And then we do some funding announcements through SAMHSA and through some of our other partners as well. So if you want to check us out, that's a little bit of what's available to kind of pique your interest. As far as our newsletter, we do some regional highlights throughout Region 5. We feature some experts within our region and a little bit broader. We feature some Great Lakes neighborhood articles that are a little bit deeper into our rural regions, and we do connections to SAMHSA, our technical training centers, technical transfer centers, and some of our other partners. So feel free to get signed up for that newsletter. We'll be putting the links for that again into the chat a little bit later towards the end of the session. Also want to briefly just highlight that as far as engaging in our session today, we want to create a space that makes training and education comfortable for everyone. We promote the use of affirming person-first language when we're discussing behavioral health disorders. So we want to just remember to use non-stigmatizing, recovery-oriented language that can really help reduce that negative bias and promote successful engagement in treatment and recovery. So again, just creating a space that's comfortable for everyone. I want to welcome Dr. Cara Poland and Dr. Jonathan Stoltman, who are our presenters today. Recognize that they're taking their time out to do this presentation for us today. And I will now stop the share and hand the presentation over to them.
Awesome. Thank you, Amanda and Jen, for having us here today. I am going to share the slides here. And that should be full screen now, Amanda, is it? Cool. Thank you. Awesome. Thank you, everyone, for taking the time this morning to join us. We have a wonderful set of slides here to go over with you and some additional information to help you all out with this really, really important topic. Cara, do you want to start with a quick introduction about yourself?
Sure. I'm Cara Poland. I am a medical physician with subspecialty training in addiction medicine. I did a formal fellowship at Boston University back in 2012, 2013.
Great. Thanks for joining us, Dr. Poland. And my name is Jonathan Stoltman. I did my PhD from West Virginia University, and I've been doing addiction science research for over a decade now. And currently I'm director of the Opioid Policy Institute. So for disclosures, we don't have any financial disclosures to talk about today, so that's nice. We're going to talk through a little bit about what we're calling the new science of addiction. We're going to talk a little bit more about opioid addiction specifically, and then learn about harm reduction and treatment for pregnant and parenting people who use drugs. So I get to do the first part here, which is fun, where we talk about the new science of addiction. And so what we're going to do is break down some of the key elements of drug use and addiction, just to do a level setting exercise, because we know that the audience has a wide range of experiences. So one of the first questions that we usually get when we think about drug use and addiction is, why do people even use drugs? And there's actually a lot of misunderstanding about this, even though it seems fairly intuitive. So for example, some people might use drugs just to feel good, so to increase euphoria or self-confidence. So if they're, for example, having a bad day or maybe have depression, they might use drugs to help pull them out of that. Sometimes to feel better or to reduce stress or anxiety. So let's say there was a hard day at work, or you're engaging in social situations and you don't normally enjoy engaging in social situations. Maybe you're a little bit more introverted, or maybe you have a situational anxiety. And so you might, for example, drink at a conference that you're attending because you're interacting with a ton of people and you just want to be able to interact in that situation better, quote unquote. To do better, these are performance-based types of things. So some people take stimulants, for example, like ADHD medication, to perform better during exams. So for example, I know college campuses, it's a big issue still during exam weeks that people will use other people's medications to try to perform. Curiosity, of course, social pressure, and then to reduce withdrawal symptoms. The main takeaway here is that initiating drug use isn't always voluntary, and that addiction itself, of course, is not voluntary. So when we think about drug use, it's really a wide range of different experiences why people start drugs. But nobody who starts using drugs thinks, well, someday I'm going to be addicted to drugs, I'm going to lose my family, I'm going to lose my jobs. Of course, that's not a reason why people start taking drugs, but it is a consequence for some folks who use drugs. There can, of course, also be problems associated with drug use. It's not that they are totally benign. So for example, you might have the perceived positive effects. So while you might be feeling good while using drugs, you might still cause harm to other people. Some individuals have to escalate drug use to feel the same. So if you've been taking drugs for a little bit of while or drinking alcohol for a little bit of while, we know that you can develop some tolerance. And so you have to start to take more to have those similar effects that you had when you first started using. And that escalation of drug use can be problematic, of course. And then with drugs inherently, there's a perceived high level of control. So most people who use drugs will say that they have a high level of control, and that can be people who use drugs infrequently or people with a severe substance use disorder. And so that perceived high level of control kind of cuts across all of those things. Again, very few people think when they start using drugs that they're going to have a problem with drugs, because we all think of ourselves as having really high levels of control over ourselves and our environment, but we know that to not be true in most situations. And of course, the drugs themselves actually impair the ability to exert control. So all of those factors kind of together can be that recipe for developing a drug addiction. It's worth pointing out here too that not everybody who uses drugs, of course, develops a drug addiction, and not all drug use is in itself problematic. When we're talking about pregnant and parenting people, there's of course different factors to consider when we think about those risks associated with drug use, but drug use in itself is not addiction, which we'll talk about here in a second. So how these slides are kind of broken down is to the various elements of addiction, because we think that that's a really nice way to center the conversation. So we're going to start with the definition of addiction here, but we're also going to talk about prevention, harm reduction, treatment, and recovery, and how those elements could manifest in trying to address this crisis. So when we think about defining addiction, the definition that we love is from the American Society of Addiction Medicine. And I'm going to break down each of these elements because they're really important to understand the key components. And each word here is really very specifically chosen by the people who developed the definition. So addiction is, of course, a treatable chronic medical disease that involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And then prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So now we're going to break down those key elements here. And then Cara, in her part, is going to tie those into why these are important elements when we think about treating addiction and our community-based approaches to this crisis. So addiction is, of course, treatable in a chronic medical disease. There are evidence-based treatments. They should be more available in rural communities. As you might know, being someone that works or lives in a rural community or does research in rural communities, they're not always as available as they could be. And so what's important at a baseline is understanding that there are evidence-based treatments, and that we then need to, once we understand that, we need to work to make sure that they are available in our communities. Cara is going to talk about those specific ones for opioid use disorder here in a bit. Addiction is chronic in that it usually lasts a year or more and requires ongoing medical attention, and it might limit activities of daily living. And importantly, there's not a cure. And so why this is important is when we're thinking about setting up those structures to help people with addiction or in treatment or long-term recovery, it's that it's a chronic disease. So we need to make sure that those structures are in place to help that individual throughout the course of their life once they've developed an addiction. It's also important when we frame addiction and when we're thinking about setting up those facilities that like treatment isn't a one-off thing. You go to treatment, it's cured, and we're moving on. We really need to make sure we think very holistically about this disease to make sure that those supports can really help individuals. And of course, it is a medical disease. And so that means that treatment should involve medical professionals and science-based approaches. And that is, again, leaning back into those evidence-based treatments that Cara will talk about here in a little bit. And then it's multifaceted. It's super complex, both in terms of the development of the disease and the course of the disease. There are similar factors associated with developing it, and there are similar trajectories with the course of the disease, but there's a lot of different ways that addiction can manifest. And so some people who use opioids, for example, they might use them. I know some people, maybe some of you on the call, have maybe had opioids prescribed to you for a procedure and you really didn't like them. You got sick, you threw up. Some people report, having sleep disturbances, and you're like, I don't even like those things. I never used them again. They were not great. And then there's other people who use opioids and it just all clicks for them. It maybe relieves some of that underlying depression, anxiety. It slows things down a little bit. It helps treat some of the pain that they were experiencing. And then you can see how those two profiles really respond very differently to the same medication. One of those individuals is at a much higher risk or a higher risk of developing addiction than the other individual. And so that doesn't mean that one person, of course, is better than the other. And that's why those stigma elements are important, but it is super complex. And that is those brain circuits, genetics, the environment, and those individual life experiences all kind of come together to create that risk profile for addiction. And then importantly, continued use despite those harmful consequences is a characteristic of the disease and not a personal failure. So when I mentioned a couple slides ago that one of the ways that drug use can be a problem is that escalation of drug use and that perceived control. So some individuals will continue to use drugs even though they're experiencing those harmful consequences. And that may be a lack of access to treatment or a lack of knowledge about treatments that are available in the community, a lack of knowledge in the providers in the community to identify that that individual is having problems associated with their drug use and that they need to help them out. And so all of those things kind of create this circumstance where that continued drug use, even though there are those harmful consequences, it's easy from the outside to look at that and say, whoa, like clearly there's some stuff going on. I can't imagine why they would continue to use drugs, but that individual that's experiencing that will continue to have that drive to use those drugs, whether for the withdrawal or the underlying things that the drugs are helping alleviate in them, especially if that underlying environment around them isn't able to help them connect to treatment. So that's why it's really important to not, of course, see that continued drug use as a personal failure, but as a result of the disease itself. This, again, manifests really importantly in pregnant and parenting women, because a lot of people see pregnant people who use drugs and think, I can't imagine why you would use drugs when you're pregnant, because, there's a baby involved, there's your own health. People don't even eat soft cheeses when they're pregnant. How could you possibly shoot heroin? But the reality is the continued use of those drugs is a characteristic of the disease and not their own moral failing or weakness. And we'll explain that a little bit more in Cara's part. And then, of course, really, really important prevention and treatment work. Like I said, there's evidence-based treatment. There's also evidence-based prevention. And so when we're thinking about our communities and approaching this crisis, we want to make sure that the prevention approaches, for example, that we're doing in our schools are evidence-based and supported and grounded in what we know works, both in a cost-effective way and that actually leads to the outcomes that we're hoping for. And then, of course, that there is treatment and that when we reframe our understanding of addiction as a chronic disease, where there is treatment that should be available, we can start to attack this problem in a very different way, as opposed to one that focuses on personal failures or morality. Addiction, of course, exists on a continuum. So like I said before, some people might have a substance or use substances. Some people in college, for example, or in high school, they experiment with different types of drugs. And then they just never really stick for them. And then they, graduate, they move on, it doesn't end up being a problem. Other people start using drugs in high school and, something else clicks in them, and then they start using them more frequently and can, progress to developing an addiction. And so, the difference in that continuum is not easy to see from the outside, of course, and it's really easy for us to impose our own risk profile on other people. So for example, if you're somebody that drinks alcohol but drinks it very infrequently, if you see somebody that overindulges or has problematic alcohol use, it's really easy to look at that and say, well, why can't they get a grip on that? Like I have control, quote unquote, over my own alcohol use. And that's why it's really important to understand it as a continuum and that all of our risk profiles are different. It's also important to think through that there's mild, moderate, and severe types of addiction or substance use disorder. For these talks, I'm using addiction as a replacement for substance use disorder, just because I know it's a bit of a broader audience. But the substance use disorder is the clinical diagnosis for it. So we might switch back and forth, but it's essentially the same thing. And what's key here in understanding the continuum element is that with the mild, moderate, and severe, the best outcomes are the ones that intervene early. So we really want to catch these things as early as possible, just like with other chronic diseases. If you catch it earlier, the outcomes are better. It doesn't mean that we can't work with an individual with a severe addiction, but it's a lot harder to pull someone in when they've been using drugs for 5 to 10 years and had this really severe experience, because they are going to experience all of additional underlying trauma and problems associated with that drug use. Where if we start to identify it earlier and provide treatment and provide prevention and harm reduction services earlier in the progression, we can hopefully prevent some of that development of a more severe disease. So it's important to think about it again on this continuum approach. Addiction, again, super complex. Like I said, I won't belabor the point too much, but I really do like this image in that it shows that, it's biology and genes, it's the environment, it's of course the drug use itself. So early use, the availability of the substances, and how that interacts with your underlying brain mechanisms can contribute to your development of addiction. For example, with some drugs, when it was, in the early 90s, when opioids were less widespread, it was a lot harder to get them outside of urban environments. I'm from Detroit originally. You could always get heroin there, right, since the 70s. But where we're seeing this issue kind of evolve is that the availability of those drugs become much more wide in rural communities, and that includes drugs that were previously not seen in those communities, which contributes, when we have those underlying environmental factors and those underlying genetic factors, kind of leads to us having that explosion of addiction in some of these rural communities that we're seeing. So it's, again, very complex, but in some ways, the ability to work on this issue is fairly simple if we focus on evidence-based approaches to prevention, harm reduction, treatment, and recovery. Why is it not advancing? Sorry. All right, so next we'll talk a little bit about prevention here. And prevention, what we mean by that are just activities to educate and support individuals or communities to prevent the use and misuse of drugs and the development of substance use disorders or addiction. And there are, again, evidence-based prevention. So like with other diseases, addiction is progressive. So that means that those harms increase over time. So again, when we think back to that continuum model, trying to kind of nip it in the bud or have those earlier interventions leads to better outcomes. It is similar to other types of diseases and chronic diseases. When we think about cancer, we have those different stages of cancer. The earlier you intervene with cancer, the better likelihood that the treatment is going to be effective. Addiction is very similar in that way. Earlier use of drugs is associated with worse outcomes. So trying to prevent or delay initiation of drug use is one of the best ways to try to reduce those bad outcomes going forward. Prolonged drug use is associated with worse outcomes. And so prevention in itself reduces many of those risks because it kind of delays that initiation or prevents it entirely. And then, of course, drug use can be associated with times of transition or stress. So, for example, again, going back to college students, but even broader audience, so maybe work disruption, housing disruption, maybe a health crisis or some sort of family crisis. Those can be risk factors for either returning to drug use or initiating drug use because there is that time of stress. And so what's really important during that time is that we've built up the skills in the individuals and the supports in the community to try to help that individual in that time of crisis. And so that's why some targeted times for prevention can be really important. Like, for example, around the holidays, you're starting to see more, at least coverage and conversations around, not overindulging during the holiday season, because that is in itself a stressful time for a lot of people, whether it's family, work, whatever, end of year stuff. So trying to think through how can you target these prevention efforts during certain times of year can be really effective. Okay, Talk a little bit about harm reduction, and Cara is going to go over some great examples for harm reduction, specifically with opioids and in pregnant and parenting. But basically, harm reduction at its core is just helping people and communities avoid the negative effects of drug use. So the goal of harm reduction is to better the lives of individuals and their communities. It's really about meeting people where they are with kindness and respect, and I can't emphasize that enough. Harm reduction is about respect, dignity, and compassion, and seeing a person as a person, which I know sounds like super intuitive. But when we think about people who use drugs, oftentimes we tend to other that individual and think of them as less than us or weaker or having low moral character. And so harm reduction is trying to flip the script on that and just remind people that just because they're using drugs doesn't mean that this is a person in front of you that can and does deserve kindness and respect. Harm approaches are also evidence-based and they're whole person associated to support the individual in active addiction. There's a ton of different ways harm reduction manifests in other public health interventions like speed limits, seatbelts, helmet laws for motorcycles, sunscreen, all sorts of things that we know can help reduce both harms to the individual and improve overall community well-being. And again, Cara is going to talk about how this specifically manifests in opioids. But at its core, it's an evidence-based approach that has really great outcomes that we could use more of in our communities, especially rural communities. Treatment, again, addiction is treatable, but it's not curable. I wish that there was a cure. There's a lot of great people working on trying to understand cures to addiction, but we're just not there yet. And so it really helps to, again, pull us back from that framing of treatment is a cure. Treatment is a chronic, treatment, like for any other chronic condition, should be ongoing. It should be assessing the individual with where they're at in their treatment trajectory, in their personal trajectory, and making sure we're providing that ongoing support. If it was as easy as somebody just walking into a clinic and getting treatment and then being done, we wouldn't be in the crisis that we're in now, right? And so at its core, it seems intuitive that addiction is not curable, but there is treatment that can be effective in trying to reduce some of these symptoms. Return to use can be part of the addiction process for some individuals. And so what's really important to that is if somebody was in treatment and then they return to use, not again layering on shame and blaming and thinking about them as weak or unable to meet their treatment goals. Sometimes it's just part of the process, and maybe it means that the treatment itself wasn't clicking or that they needed additional supports. And so it's really a time to evaluate our approach as opposed to blaming that individual. And then, of course, there's evidence-based treatments. These all depend on the substance. Cara is going to go over the one specific for opioids that some of you may be familiar with. But basically, there are a number of evidence-based treatments that are available. There are medications, there's behavioral treatments, and we want to make sure that that full suite of options is available, just like there would be for other diseases. And then, of course, usually it's a combination of medication and behavioral therapy. The medication at its core is treating withdrawal, trying to reduce cravings and preventing return to use. And then behavioral approaches can help modify those attitudes and behaviors that might contribute to drug use or contribute to returning to drug use. So like I said, return to use is a sign that treatment should be modified, not that that individual isn't strong enough, isn't trying hard enough, is a failure, has weak moral character. It's really a sign for us in our community that there are other things that we should be doing to try to help support this individual. And that in itself is a really big way to reframe how we understand drug use and addiction. And so if we have treatment in our community and oftentimes people see it or they've experienced it with a loved one or a family member and they return to use, and there's a lot of frustration that comes with that. And I totally understand it. But that typically means, again, that there's just more that we can be doing to help that individual. And then I did want to stress again, addiction is similar to other chronic diseases in that it is preventable. So there's those evidence-based preventions. There's treatment. There's evidence-based treatment that Cara is going to talk about. It changes the underlying biology of the individual, but there's other things that change that underlying biology too, like treatment. And just aging in itself changes biology. Different stages in our life course, like pregnancy, changes our underlying biology and can increase or change our risk. And so addiction itself, changing the biology, doesn't mean that it changes it in a way that that person is broken and can no longer function in our society. It just means that they need some additional help and support. And then, of course, if untreated, addiction can last a lifetime and be life-ending for some individuals. So this is a really important thing that we should be working on to provide treatment in our community. All right, last thing quickly for me is recovery. There are many paths to recovery. Stopping using drugs and resuming productive lives is like the goal of recovery. And I know productive sounds very like capitalist, I don't know, like economy. But the idea there is that this individual can contribute either to their family or culture and society at large, and is able to resume what would be defined as a productive life. Again, I know that's a really weird framing, but those are the words that are used associated with recovery. And stopping drug use isn't the goal for everyone. And that's really important to acknowledge as well, especially when we think about pregnancy or during parenting. There may be reasons why stopping drug use is a goal for us as people that are loved ones or that care about those individuals, but that might not be that individual's goal. And so you want to make sure that they're working with a trained provider and working on, working towards their own goals, and that we're not imposing our goals on them. But again, there are some drugs that, like drug use during pregnancy, can increase risk. So it's not like the best thing in the world either, but it's really easy from the outside to say, well, why don't they just stop? But that's not really the goal for everybody in all situations. And so it's just one part of a long and complex recovery process. When we're starting treatment, the drug use often has caused various serious consequences in their lives, whether it's a trauma that you experienced during drug use, trauma that you've experienced prior to starting drug use. And so all of those things also need to be treated during that process of recovery, because oftentimes when we think about drug use and addiction, basically what that's done for some people is it's put kind of a mask over some of those underlying issues, and think of it as a Band-Aid. And so once that Band-Aid is ripped off, there can be some of those underlying harms that kind of start to come back to the surface. And so we want to make sure that we recognize that, again, just one bout or one go of treatment isn't enough to treat all of those things in any one situation. It's not like some 30 days in anywhere would resolve a lifetime of these issues or years of trauma. And so we want to make sure, again, we're thinking about this as a chronic sort of long-term thing that we need to support folks with. We also want to make sure that when we're talking about recovery, we're not just focused on the drug use, but the needs of the individual broadly. So for example, housing, employment services, childcare services, all of those things that we think about in general broad context with individuals and that are a part of a lot of our lives. People who use drugs also need those things, right? And so we need to focus on the whole person and not just focus on that drug use, because that might not actually be the biggest thing that's causing issues right then. It might just be that we need to set them up with stable housing so they have a safe place to live, and then we can start to address some of these other underlying things. And then, of course, recognizing, I know there's been a lot of focus on overdose deaths, and rightfully so for opioids, not enough focus, I think, on alcohol and other related harms with like alcohol, tobacco, vaping, all those things. But what's really important is to recognize that there's 25 million people in the United States in long-term recovery right now. That's a huge number of folks. And so there are paths to recovery. We just need to make sure that we grease the wheels for those paths to help folks out. I'm not going to talk too much about this, but I really like this slide from NIAAA, which is a branch of NIH. And basically it's focused on alcohol, but it shows that there are a ton of different paths to recovery and that we shouldn't prescribe any one path for individuals because everybody has different needs. So for example, some of these folks might need more intensive treatment. Some folks might just need to see a primary care provider that can prescribe the treatment medications. They do some support groups and they're on their way. It really just depends on some of those other underlying risk factors and how long they've been using the substances, what substances they've been using, what their other social supports look like, et cetera. And so when we think about setting up these supports in our rural communities, it really helps to broaden our understanding of there's not one way to recover. And we need to be flexible and meet people where they're at, which again is that core of harm reduction. All right, I'm going to hand it off to Cara. She does a wonderful talk with these slides, and take it away.
Thank you so much, Jonathan. Thanks for setting us up so nicely. We are going to now focus, as Jonathan said, sort of on the opioids more specifically. We know that opioids are substances that work on opioid receptors in the body. The opioid receptor in the body that is most commonly cited is the mu opioid receptor. But it's also important to note when we talk about opioids that there are other receptors involved. And depending on which treatment you're using, they may target different receptors. And there's a lot of work and studying going into, can we develop opioids that are more specific to the pain receptors? Can we develop opioids that are more specifically targeting treatment, treatment for substance use disorders? So it is I think we kind of generally speaking, oversimplify to, opioid receptors, and often focus on the mu opioid receptor, but it's important to know that there are multiple. We do have many, many different opioids out there. I always like to note that heroin is a Schedule I medication in the United States. So we have determined through our scheduling process that there are no medicinal benefits to heroin. But over in Great Britain, they still use heroin in end-of-life care. And for things like anesthesia. So it's not that these medications, I always tell people, are just very, very powerful, and we have to respect their power. And especially when working with perinatal folks, right at the end of a pregnancy, there's labor and delivery, which I felt like for myself, I have delivered 2 children, that even though I knew with my second one kind of what was going to happen because I had experienced a first labor, it didn't make it really easier, right? So it's an emotional time in people's lives. It's an emotional event, and we know that when it comes to substance use, things that trigger our emotions can make us respond more strongly in that pleasure reward system. And so, we want to make sure that when we're working with pregnant and parenting people, we're having those conversations with them. We're talking to them about the power of these medications, that we understand when they go through labor and delivery that, there's a time and a place for an epidural for many, if not most individuals. And we don't have to, while we want to have a birth plan and kind of think through what we might want in an ideal situation, very rarely is that really what happens, because labor and delivery kind of happen on their own terms. So just, wanted to refocus us into the opioids and into that perinatal space. The medications to treat an opioid use disorder in the United States that are FDA approved include the buprenorphine and the methadone when we're talking about opioid-based medications. Of course, naltrexone is also FDA approved to treat opioid use disorder as well as alcohol use disorder, but it is not an opioid, so that's why it didn't hit this slide. Next slide, please. So we're going to kind of do the same thing and go through these different, this diagram and these different steps. So we're going to start by talking about what it looks like for somebody to have opioid addiction. Next slide, please. So when we talk about developing an opioid use disorder versus having opioid use versus having substance misuse, we have to be a little careful because not everyone who uses substances has a substance use disorder. We know that according to the DSM-5 revised criteria, we have to have at least 2 of the 11 criteria to diagnose a substance use disorder, but tolerance and withdrawal themselves are not are not enough to have a substance use disorder. So how I like to interpret that is that it means that, anybody who's on chronic opioids is going to have tolerance and withdrawal, but you have to have something that is sort of discordant in your brain, something that doesn't make that substance use feel good or right or safe for that individual to truly diagnose them with a substance use disorder, which is why sometimes when we're talking about harm reduction and we're talking about people kind of in that what we often term a pre-contemplative stage of change, really the accurate diagnosis for them is substance misuse. If they are not perceiving that there are problems or difficulties with their substance use, then it's sort of difficult to diagnose a substance use disorder because that DSM criteria sort of relies on there being something that is, again, that discordance within how that person is feeling about their substance use to really diagnose that substance use disorder. So substance misuse, I think, is an underutilized term that I'd encourage you to think about. Of course, the reality of life is that if you are a clinician working with clients or patients, however you want to term that individual, for billing purposes, we often have to put a substance use disorder diagnosis down, and that substance misuse just really isn't isn't reimbursed by all insurances. I know in the state of Michigan, we actually don't reimburse at the same level for substance use versus versus a diagnosed substance use disorder. So the question in the chat is, what about situations where their close family or friends clearly see that it is causing problems that the individual doesn't see it? It has to have that disconcordance for that individual. So it's hard to diagnose a substance use disorder without that person's perception involved in it. So substance use is simply the use of a substance, and without any sort of caveat on how that person is interpreting it. So as you can see at the bottom of the screen, this also extends to pregnant people. So using drugs, including opioids, during pregnancy does not necessarily equal addiction. It does not necessarily mean that individual has a substance use disorder. Next slide. So opioid use disorder and pregnancy rates are both increasing. And so what we see is that opioid use during pregnancy has increased pretty significantly starting in the early 2000s, along with, and we do see that continuing to increase kind of essentially in parallel with the national trends for non-pregnant individuals as well. And along with that, we see a concurrent rise in neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And so we like to emphasize too that abstinence syndrome or that withdrawal syndrome in the neonate is a treatable, time limited, expected possibility for any infant with a prenatal opioid exposure. However, not every baby who is prenatally exposed will have a withdrawal syndrome. So we often use mitigation strategies and monitoring strategies to work with that individual, to work with that family as a unit to decrease their risk of now. So we know that through things like rooming in and utilizing Eat, Sleep, Console over Finnegan scoring, and sending babies to nurseries for monitoring, that connection with the family unit can actually help keep that baby calmer. I always tell my patients, we want you to be with your baby because we want you and your baby bonding together. We want you and your baby to have that kind of warm cuddle time. And honestly, we can't tell the difference between I miss mommy and daddy, or I miss my caregivers, right? I'm having withdrawal, right? So we want to make sure that we keep those the people that have been involved during that pregnancy, the people that have been supporting that pregnant person, involved in that care of the neonate to try to prevent some of the withdrawal syndromes. We also see that when we do this, the rates and the risk of us identifying a newborn as being in withdrawal are limited, are decreased as well. And then one of the starkest statistics is that mortality more than tripled among pregnant and postpartum women aged 35 and 40 to 44 years old very recently from 2018 to 2021. I just do want to put a note. We try to use inclusive language around pregnant and parenting individuals, but some of the studies still talk about pregnant and postpartum women, so we have to kind of maintain fidelity to that language, to the language of the study as well. Next slide. So we do know that there are some complications from an untreated opioid use disorder during pregnancy. There's a fear of attending prenatal care for somebody who's not kind of following the standard recommendation of care. We see this in other disease spaces too, right? We see that the person who has uncontrolled diabetes with a hemoglobin A1C of 17 pre-pregnancy, sometimes has delayed prenatal care because they're worried about what we're going to say as the healthcare system about their diabetes control. We see that, with all sorts of chronic illnesses. But then we judge the patient for not having the prenatal care. And so it kind of becomes a self-fulfilling prophecy, right? They are scared to come see us because they're worried we're going to judge them. They delay coming see us because they're nervous. When they come see us, it's delayed. And we're like, well, why didn't you come sooner? Also compounding this with opioid use disorders is opioids themselves. Remember I said that they do a lot of other things besides substance use and addiction. They actually kind of interfere with the sex hormones. And so they can decrease sperm counts and they can disrupt ovulation. So particularly for people with uteruses and with intact ovaries who are menstruating, their menstrual periods may be eliminated or may be very much more irregular. So they truly may not realize that they're pregnant for longer. I always tell people that I did IVF with my son. And if I hadn't done IVF, I wouldn't have known I was pregnant until I was 20 weeks pregnant. I didn't feel anything. And then with my daughter, I was sick as can be the whole pregnancy. So you just never know, right? And so sometimes when people come in and they say, I didn't know I was pregnant until, and now I'm 22 weeks pregnant, especially if you're having those irregular or suppressed gonadotropin hormones, it may actually be accurate that they've only had, a handful, 3-4 menses over the last couple of years. And when people get into treatment, their fertility often increases, even if they stay on opioids, because they're on a consistent amount, whether it's the methadone or the buprenorphine. And part of the way the gonadotropins work is that pulsatile up and down release of it. So when they're not getting up and down release of opioids, and they're on that kind of consistent medication, their menstrual periods can come back, their fertility can increase, sperm counts can increase, and so it does still increase fertility when somebody is on medications for an opioid use disorder. Going back to the pregnancy complications, we do see an increased risk of fetal growth restriction, including for people who are on medications for an opioid use disorder. But the fun thing about that is the recommendation is to have an additional ultrasound at between 32 and 34 weeks. And I have yet to have a pregnant person complain to me about going for an ultrasound. So try to get them to go to the lab to get lab blood work, and that's a whole different conversation. But hey, let's take a peek at your baby. Is like everybody wants to do that, so it's kind of a fun one. I that's how I frame it. Hey, we get to check your baby out like one more time than most people. Isn't that fun? You're gonna get like an extra set of pictures, right? So like you just kind of try to frame it in a way that like makes it cool for the patient. The abruptio placentae is where the placenta can kind of come disengaged from the uterine wall. And so that can result in pregnancy loss or termination. And then, of course, there is a risk of fetal death as well as preterm labor. In my clinic, we tend to see that, knowing that we usually are delivering these individuals closer to 39 weeks compared to the 40 weeks for full term by recommendation from the obstetric team. Our average delivery gestational age is about 37 weeks. So a little bit over 37 weeks, so not technically resulting in formal prematurity. Which is great for those patients that are on medication for an opioid use disorder. So it's also important to remember that opioid use disorders don't live in a silo. Our patients can still have diabetes, hypertension, preeclampsia, but also they have a higher risk of having co-occurring mental health conditions, particularly in the perinatal period. We're often talking about perinatal depression and anxiety. I think we don't talk enough about postpartum anxiety as a real thing. We know that all people after they deliver around 5 days postpartum, everybody has what we call the baby blues, just from that general hormonal crash that occurs after delivery. And so we want to just be really mindful that when we do eat, sleep, console, and rooming in, often we're keeping the family there for 5 days for that monitoring period. And so we're actually discharging them when they're at the nadir of their emotional tolerance. So they're most likely, we need to make sure that part of that discharge, oftentimes it's the neonates that's being discharged because the pregnant person has already been discharged in the postpartum period. And so we need to make sure that we put in policies and procedures around ensuring that we do perinatal depression and anxiety screening in that time, of the pregnant person on discharge. Of course, many people with a substance use disorder, as I'm sure we're all aware of, have a increased risk of a history of trauma, increased risk of a history of PTSD, and both of those can make it so that they become their bodies are just more excitable, and coming into a stressful situation, read the hospital, read labor and delivery, can increase that. Can kind of increase that fight or flight response. So really ensuring that staff are well trained in trauma-informed care principles is very helpful for approaching this population. And let me just be clear, like, I personally would love it if all my clinicians approached me with using trauma-informed care principles. It's just like a calmer, nicer way of approaching our patients. And I try to practice it regardless of who I'm seeing, because it just makes sense to create as safe of an environment for our the people we're caring for as we can. Next slide. Now we're going to move on to talk about harm reduction. And what we want to, as Jonathan set us up so nicely, we want to make sure that people avoid the negative effects of drug use. I often think of harm reduction as a way to keep people safe if and until they're ready to enter formal treatment. In West Michigan, we're fortunate to have a large, actually the second largest harm reduction organization, Grand Rapids Red Project, after the harm reduction organization in Chicago. So I think we're doing pretty good because we're quite a bit smaller of a city than Chicago. So we're really fortunate to have a really robust harm reduction system. I was actually personally at my PCP yesterday, and there was like a naloxone kiosk where you could just like open it up and pull out a bottle, a box of naloxone in her lobby. And I was like, I got really excited. Being that, like, I took a picture, sent it to my husband, who probably is not a clinician of any sort. He's a software engineer. He was like, great, nice. I'm like, you need to be more excited. He's a software engineer. He doesn't do excited. But some of the just general principles of harm reduction that Dr. Stoltman went over are very much pertinent to the pregnant and parenting population. And remembering that if somebody isn't ready for treatment, but they're coming in for prenatal care, shows that they're trying to do the right thing for where they are in their substance use disorder. And just like we wouldn't tell somebody, who we didn't feel was taking their hypertension medications or their diabetes medications, or missed that, referral to whichever specialist we tried to send them to during their pregnancy, that because you didn't do the things we said, we're not going to care for your pregnancy. We don't want to do that in this space either, right? We want to make sure that we continue to create a welcoming environment, but that we provide them with the appropriate supplies to keep them and their pregnancy as safe as possible. It's important to note that breastfeeding can reduce opioid withdrawal. Breastfeeding can reduce opioid withdrawal in infants. However, there are definitely recommendations around breastfeeding in the context of illicit substance use as well. And those can be slightly variable by institution. So I don't want to make any blanket statements. Next slide, please. So these are some of the general harm reduction approaches. Syringe service programs. So we want to make sure that people have access to unused syringes and are not being encouraged to reuse them, right? We wouldn't tell somebody with diabetes, oh, it's okay, you can just use that same syringe for like 4 days to inject your Lantus. That's cool. We shouldn't be doing that in this space either, right? And then, maintaining availability and the options open throughout the pregnancy, because sometimes things can change for individuals as they go through pregnancy, to access medications for opioid use disorder. I mean, I think everyone who walks into like any clinic, like my primary care clinic, should just be offered naloxone as a blanket statement, because the more naloxone out there, the safer the community is. And then as appropriate, HIV screening and treatment along with pre-exposure prophylaxis, again, if appropriate. Safer consumption spaces, or creating spaces where you are safer as a drug consumer. So that may mean using in a location with other people, having drug testing available, having sterile water, sterile cookers for opioid use, glass pipes, disposable glass pipes if they're using inhalation techniques. All of those types of things can kind of also be part of a safer use system. And then fentanyl test strips, and I mentioned drug checking. We tend to be moving more towards drug checking because almost all, I found that in many places in the Midwest, Grand Rapids included, we still call everything heroin, even though it's almost unequivocally fentanyl. So I don't know if that's true for where you are, but fentanyl test strips have kind of become a little bit more obsolete, because almost all opioid supply has fentanyl in it for that purpose. But where fentanyl test strips do come into play is with other substances. So to check for adulteration in other drug supplies, whether that's the cannabis supply or the methamphetamine or cocaine supply, but for people who may be getting adulterated other substances. I usually tell my patients, it's not like our drug dealers follow OSHA principles and there's like the safe hood where they are mixing the fentanyl and then the next hood where they have the cocaine, right? They've got like a kitchen table and, cross-contamination occurs, right? So it's kind of usually gets a little bit of a smile out of my patients and they go, yeah, that's possible. And I'm like, well, so maybe we should get some fentanyl test strips for you. Next slide. Opioid. I'm sorry, I'm trying to monitor the chat a little bit, but I'm sort of doing a crappy job. Free naloxone dispensers at local health departments in Wisconsin as well. So that's awesome. And then Michigan has like an online naloxone portal where you can just go order naloxone by the 12 pack, which is fantastic. I've got 3 boxes in my office right there. Sorry, did somebody go to unmute themselves to add something to naloxone accessibility?
Cara, I just wanted to know, did you see, Sheila had, what situations when their close family and friends clearly see that there's causing problems, but the individual doesn't see it?
Yeah, she answered that one already, Amanda. And what postpartum anxiety and depression screening tool do you recommend? But some of these questions can wait until the end too.
Okay. So you guys are monitoring them. So if you need to interrupt me, then interrupt me. I will not flummox my words so much if I'm not trying to watch both. Awesome. Thank you. But feel free to interrupt me. So opioid overdoses, it is the highest risk period in a person who has a pregnancy's life, is that first year postpartum. So we see that in the 3 to 12 months postpartum is the highest risk time period in that individual's entire life for an opioid overdose. And so what happens, I think, for a lot of people is that when they're pregnant, there's a lot of support coming in right after they have the baby. There's a lot of people who are excited that they had a new baby, so they might have some additional support. Things are all still really new. And then by the time you get to 3 months postpartum, you're still exhausted. Your baby's still not sleeping, 12 hours a night, 8 hours a night. And you don't have as much support. So in our clinic, we try to hold on to people for that first year postpartum so that they can maintain those relationships with our treatment team. And we can provide them with a wide berth of time period during which they can change to the next, during which they can move to the next clinical space as appropriate in their life, rather than kind of the more traditional 6 weeks postpartum in the OB world and out. We try to provide a longer leash, so they may leave anywhere from 6 weeks postpartum to a year. We've had some people that have clung on till 18 months and things like that as well. But just really kind of knowing that we want to kind of shower people with support and really be available and monitoring for safety in that first full year postpartum. And opioid overdoses are reversible, again, naloxone, naloxone. And as people's kind of bodies and metabolism change, whether they're on MOUD or otherwise, their opioid needs sort of can fluctuate, and that can be disconcerting for people, whether they're using illicit supply or an illicit supply. And so it's important to make sure that they know to reach out to their treatment teams or their harm reduction organizations for additional support as needed. Next slide. Let's skip this one. We talked a lot about naloxone. I'm sorry, guys. I'm just like talking about stuff as we go. Treatment. So we know there are huge treatment gaps. I probably don't need to say this to this group, but most people who need addiction treatment don't receive the treatment that they need. Next slide. So we know that there were about 2.5 million adults with opioid use disorder, and nearly half of those were women, and then the largest portion of people who did not receive treatment, who did not receive evidence-based treatment, so standard of care, end up being women. So men are more likely to receive higher quality evidence-based addiction treatment than women are. Next slide. We mentioned some of this already, but treating opioid use disorder in pregnancy is crucial because we know that if we can engage people in treatment, if we can engage people in medication management, we have improved outcomes for that whole family unit. It's also important, we talk about treating opioid use disorder in pregnancy kind of specifically to the pregnant person, but if those folks around that pregnant person need care and support, we should make sure that as we're caring for these pregnant individuals, that we have safe spaces and clinics for those individuals to go to, as well if it is not one and the same for the treatment of their substance use disorder. And we always like to point out that we have to be very careful with our drug testing. Not only is a drug test not a parenting test, but usually in our SUD clinic, they don't follow chain of custody. And so they should not be used in legal in a legally punitive manner, whether that's with community correctional control, things like probation, parole, or with child protective services, the foster care system, removal of children from homes. We need to look at that whole individual and what things are looking like. These are the 3 medications for an opioid use disorder. The first one is methadone. It's a full agonist. It generates a full effect at the opioid mu receptor. Buprenorphine is what we call a partial agonist. What that means practically is there tends to be a ceiling effect for buprenorphine, where more medication doesn't always help. And then naltrexone, again, is an opioid antagonist, and it blocks the effects of opioids. With pregnancy, the American Society of Addiction Medicine, as well as the American College of Obstetrics and Gynecology, both recommend methadone and buprenorphine during pregnancy. The jury is a little out on naltrexone during pregnancy because at the end of pregnancy is labor and delivery, and we often want to be able to use opioids. So there just hasn't been a ton of information on of high quality information on naltrexone use in pregnancy. It's also important to note, as I'm sure you've already read, that naltrexone does not, as far as the current data shows, reduce the risk of an overdose death for people who have an active substance use disorder. Next slide. MOUD benefits, we mentioned a lot of these are not super different from the non-pregnant individual. So that reduction in mortality, the decreased risk of communicable diseases, which also then decreases the risk of transfer from the pregnancy and the pregnant person's blood supply to the neonate's blood supply. And people who are engaged in MOUD tend to engage in other forms of medical care as well as psychosocial supports and treatment. So things like CBT, group counseling as well. Next slide. So we want to provide people with medication, social support, and counseling. I just pulled out this week my medication is treatment pin to show somebody who is kind of newer to the addiction field that there really was this question about whether or not medications were an adjunct to therapy or whether or not medications were integral to treatment. And the jury has really come out on the side of medications are integral to treatment. The same study that showed that naltrexone does not reduce opioid mortality showed that counseling or abstinence and counseling as well as abstinence-based programming alone do not reduce mortality from opioid use disorder. So again, the only ways to reduce mortality from opioid use disorder are to provide people with methadone and buprenorphine. The jury is still out in terms of like how long people need to be on that medication. That is a whole nother discussion that we don't have time for today, but just know that what we do know in terms of duration of treatment is that being on medication for greater than 1 year is better than less than 1 year. So we don't even want to kind of think about tapering medications for opioid use disorder after less than 1 year of treatment. Next slide. So there are a lot of barriers of care for pregnant people. Many of them are really grounded in stigma. People, there's a lot of discrimination that occur. We also, and that can come from the individual, from their family, from the healthcare system. And then for many individuals, social issues can make it more difficult to access healthcare. And I think we've done a lot more talking in general medicine about social issues, but that's been kind of a long-standing theme in substance use as well. And I want to just underscore the fear of losing their baby to family policing apparatuses across the United States. And again, those vary, reporting requirements, et cetera, vary state to state. So I don't want to go into those types of details because I don't want to confuse people. Next slide. So stigma is by definition a form of dehumanization, and we want to make sure that people feel like whole individuals when they come into our clinic. So the more we can do to reduce stigma, the better off we are. Next slide. We had a bit of a disclaimer already about safe and inclusive language, so I know that this group is very sensitive to that, but I'm just going to go through a little bit of this and maybe skip some of the in-depth discussion of these slides. Addiction stigma definitely results in discrimination, and it affects all aspects of a person's life. So there's stigma that comes internally from, that's the stigma that comes from the recovery community, stigma that comes from other close family members, friends, people in their lives, stigma that comes from the community more broadly, stigma that comes from healthcare, right? There's just stigma kind of coming at people from all different directions. And it's sort of everywhere in our society, and it really stems from this thought that substance use is a personal choice, and that if you just tried harder, if you could just X, if you could just not go to your drug dealer's house, if you could just not talk to that person, if you could just block that phone number, there's a lot of if you could just statements that people will make towards individuals with a substance use disorder that contributes to stigma. Next slide. We see this is a People magazine spread that says born addicted. Babies are born prenatally exposed. They don't have a pleasure reward center that is able to have the hallmarks of a substance use disorder. They don't have that ego dystonia that we talked about earlier to be able to define a substance use disorder. You cannot diagnose a substance use disorder in a baby that is 3 days old. It's just not possible. But we use kind of these words in the media, and we often see this in the Associated Press has guidelines around the words that we use in the media, but I really encourage you to think about, here's a picture of a crying, suffering, alone baby with the words born addicted. How does that make you feel? How does that make you perceive that baby or that baby's child caregiver or that baby, that baby's parents or other folks that are taking care of them, that they're just letting that baby lie there crying, right? This is what they're trying to get that emotional response from us, even though, we don't leave. I mean, I don't know about any of your hospitals, but we are not at my hospital excited about baby torture. So this baby would not be left crying with a hospital band on their foot. And I don't think in any of our hospitals, right? Like somebody would be intervening, checking on that baby, holding that baby, cuddling that baby, eat, sleep, consoling that baby, supporting that baby, assessing them for the need for medication, right? And so sometimes the way the media portrays substance use, and especially around pregnancy and children, can be very stigmatizing. Next slide. Words matter, the images matter, just like we kind of talked about. And we want to really change the words that we use, because that can help us reduce unconscious bias and unconscious stigma in order to better support the people that we're treating. I do a lot of training of medical students and residents, and I always tell them one really low-hanging piece of fruit to do is in the problem list, change the diagnosis from substance abuse to substance use disorder. And right now, you've already elevated the care that the patient's going to receive, because we've done studies that show that when we use the diagnosis of substance abuse, we actually provide lower quality care to that individual compared to when we use the words substance use disorder. So real low-hanging fruit, but really good proof, or at least a really good example of how we can improve the care by just changing the words that we use. Next slide. That outdated language can dehumanize people and increase that discriminatory care that they receive. And so we want to create safer, not only care environments, but communities for individuals with a substance use disorder. So if we, as the big, powerful healthcare complex, are using safer, more inclusive language around that person and whoever their support network is, that then maybe that permeates out into our community more and more and more. Next slide. So we want to kind of challenge people to think about how your approach to addiction is that consistent with how you think about other chronic medical conditions, and how can we kind of elevate the conversations that we have around substance use and other kind of patients that generally we term as non-compliant, right? Which is really a derogatory, discriminatory word to use. So I'm sorry, but that's kind of how we do it, right? Next slide. We are going to talk just briefly about recovery. So again, medication should be continued throughout the postpartum period. And again, when we talk about postpartum period, we're really including that first full year postpartum. Next slide. So all people who use drugs have a right to health and treatment. We want to provide them with caring conversations through the healthcare system that includes the ability to provide them with appropriate and safe treatment, and that feeling of mutual trust and non-judgment. I think everyone wants that when they walk into the healthcare system, and people with an opioid use disorder or substance use disorder more broadly are no different. Next slide. There are national guidelines to help us with treating pregnant and parenting individuals with opioid use disorder and their infants. This is the SAMHSA guideline, which is kind of the national guidance. Boston University also has a resource guide. If you Google search Project Respect, that comes up, and that has some very practical tools that you can align with this clinical guidance, like note templates for prescribers and things like that. So it can be helpful as well. Next slide. Here is that we just blew by our contact information because I spoke too much, and Jonathan wants to make sure we have time for discussion. I am extremely excited to ask Gresha, to have Gresha here today. Gresha and I have been working together since we were about 10 years old. So it's been about 10 years, judging by maybe a little longer than that, judging by the ages of our children. But, you know, I think I was 6 when I had my first child. But Gresha is a person in recovery, a recovery coach, and has a story about being pregnant with a substance use disorder that we think is pretty powerful. So I'm going to ask Gresha to introduce herself and tell us a little bit about her story, and then we have a few, we can answer some questions, or we can, we had some kind of discussion topics if there's not a lot that percolates up from the group. Gresha. Oh, you're muted still.
There we go. I always forget. My name is Gresha. I am a woman in long-term recovery from substance use disorder. Just celebrated 10 years last October. For me, I think stigma played a huge part in my 3 pregnancies, my 3 last pregnancies. I have 5 kids, and one passed away in 2001. So that's really what started my substance use disorder. But I faced a lot of stigma from all fronts, from my family, doctors, my community, and then eventually it got to the self-stigma, where I was calling myself an awful person. How could I keep doing this when I'm pregnant? But my first 2 pregnancies using substances they were both born a month early. I didn't have any access to any treatment. My doctor my OB actually put me on Norco to keep me from withdrawing. So I didn't get any treatment. I thought it was okay, kind of. But when I got pregnant with my daughter, I was sick, and I was sick and tired of being sick. I was high risk, so I was referred to maternal fetal medicine. In turn, referred me to a Center for Integrative Medicine, where Dr. Pullen worked. And through her support and compassion and no judgment, it created a safe space for me to feel comfortable enough to disclose my substance use disorder without fear of losing my child right after birth. I think that was really, really huge for me. So that's part of my story. Anything you want to ask? Do you want to ask any questions?
Gresha, thanks so much for joining us today. Really happy to have you on. I did want to follow up with a quick one just to get the ball rolling, and I'll monitor the chat as well. Have there been some practical ways that you've seen stigma reduction help pregnant people who use drugs, or helped you when you were facing that stigma? Like, what really helped pull you out of it?
What really helped pull me out of it is kind of the education. Education, like telling myself I am a human being. I'm not an animal, as people say, or the community says.
Well, you literally had a healthcare provider refer to you as an animal in the emergency room.
Yeah. Yes. that wasn't when I was pregnant, but yes, that was awful. When I was seeking treatment for substance use disorder about 12 years ago, I went to a couple of rural hospitals because that's the only ones that are around me. And I was right off the bat treated like an animal. And this is really it. It's upsetting. One of the doctors actually called me an animal and just said, I don't know why you can't just quit. We can't do anything for you here. And they sent me on my way. It happened at one more other rural hospital out by me. So that left me hopeless, and the feeling like nobody cared. Nobody cared if I lived or died, you know? It's a tough feeling. Even being 10 years in recovery, it still hurts. So I do all I can to try to reduce stigma around in the healthcare community and in the community around me. So it's really important to educate doctors and the medical professionals as well as the community.
Gresha, thanks so much for sharing that. And I can still see that it's really hard for you to share that. So I appreciate you bringing it to this audience. I'm wondering if you can talk a little bit about how harm reduction can help pregnant and parenting people, especially in terms of like how it can bring them into, the supports and treatment that are available in communities, and why those sorts of approaches are really important.
I think those approaches are super important to harm reduction is very important to, in my opinion, keep us alive. But I think it all boils down to compassion and support. The support makes you feel like you can have an open discussion with your doctor. An open discussion, just not just about substance use disorder too. I mean, an open discussion about our mental health issues, about, our social, everything. It creates a space where you can just have that open discussion about, it makes you trust your doctor, I guess, a little bit more.
Absolutely, because they're starting to see you. You can see that they see you as a person, and they're offering that different level of respect than clearly that you got from other types of providers too, right? Which is really, again, just horrific that you've experienced that. Cara, I'm going to start with you for this one, and then Gresha, feel free to jump in. What are some ways that the ideal treatment, because we talked a lot in our slides about what treatment's supposed to look like. We talked about evidence-based treatment. We talked about all the things that we could be doing better. But I think it would help to kind of talk a little bit about how the ideal for treatment that we just talked about can differ from reality. From your perspective, Cara, and then Gresha as a patient, how that really looks and how that makes recovery so much harder.
I mean, the biggest thing is getting the whole healthcare system involved, right? During pregnancy, you have outpatient providers that are involved. You have referral specialists. You have endocrinologists who are involved, right? Because people with a substance use disorder also have other chronic medical conditions. You have the mother-baby unit. You have the general ER. You have the delivery, the labor and delivery department. You have pediatrics involved. You have the NICU involved. And so you really have to be a very strong advocate and educate and train people about treating individuals with a substance use disorder and how that and how that can look different for different individuals across that care continuum. And really, we kind of frame it all as anti-stigma training. We want to prevent that stigma so that people receive the highest quality care possible. We also have made like little tweaks, like in the postpartum unit, only if they have a float nurse that comes in, a float nurse is not eligible to care for our people that have a history of substance use or recent substance use during the pregnancy or on MOUD, just because they have not received that that additional training. So, you know, they come in, they don't really know why the patient's there for additional days. Now we've switched, because we do rooming in, we've switched the room from the pregnant person's room to the baby's room. And so it's very confusing to people who aren't used to it, right? Because it doesn't on face value really make a ton of sense why that person would still be a mother baby and not in pediatrics if the room is for the baby. So, you know, making little tweaks like that to help people. And then, you know, I think a huge part of what Gresha also talked about was developing that trust, right? So if a patient comes back and says, I didn't have a great experience on labor and delivery, I want to know what happened, who it was, and I have my key contacts on the inpatient side, in the NICU, in all these different environments where I can reach out and say, hey, you know, I'm not mad at anyone, I'm not angry at anyone, but I think we might need to approach this person and make sure that they've done the education, maybe provide them with a little bit of a refresher or some tools, or to help us understand, you know, what maybe happened in this situation, and what their perception is of what happened in the situation, and make sure that they know how our patient perceived it. I like to think that we all are in healthcare because we want to help people. I know, not rocket science there. And so usually it doesn't come from a bad place, right? So if we go to our other healthcare providers and we kind of come in attack mode, you did this to my patient, it usually doesn't go very well because they get very defensive, because so would I. So just, you know, hey, my patient had this perception when they came to the hospital. I just want to understand, like, you know, what was going on, what happened that day. Are there things that we could do to better prepare our patient before coming to the hospital? Because now that's putting some of the blame on me. Are there things that we could, are there questions that you have about why we did what we did with that patient? How can we kind of align our stories so that we can make sure that you and the patient and the whole care team have a better experience in the future? And so really, you know, we kind of just changed that conversation. I don't know, there's probably social workers on this that are rolling their eyes at me, because y'all just probably pull out your magic wands and fix it, right? Isn't that what social workers do? Gresha's laughing because that's how I always say. I'm like, social workers have magic wands, I swear. I just have a prescription. I went to school and got a prescription pad. You went to school and got a magic wand. I clearly went to the wrong type of schooling. Gresha, what do you have to add to that?
Yeah, Gresha, did you have anything to add about how the ideal treatment can sometimes differ from the reality, and what we can do to bring it back into best practices?
Well, I mean, I think, can you repeat the question, please?
Yeah, so the ideal treatment that like Cara and I walked through today, where like everybody should get medicine, everybody should get respect and dignity, really differs from your experience, of course, and that's improved. But what do you think are some things that we can do to try to get the ideal closer to the reality?
I think education and training at hospital systems, or, you know, with medical professionals, I think that's super important. Because a lot of the stigma comes from being, I don't want to say uneducated, but from the lack of education that they received. So I think education and training is really important.
Yeah, that's great, Gresha. And I like to start, or I like to end with hopeful. And so Gresha, if you don't mind, what gives you hope about the future of like treating opioid addiction, and that we can kind of get our hands around this crisis?
I think a lot of these webinars and meeting all of you people that have that compassion, it's going to go a long ways, I think, in the reduction of stigma. That's it. Yeah.
Yeah, that's great. Cara, I'll let you unspool for a couple minutes here. And what gives you hope about the future of treating opioid addiction and addiction broadly, especially in pregnant and parenting?
My medical students and residents who are eager to actually learn about and do this work. Gresha and I do a lot of anti-stigma work at hospitals kind of across Michigan together over the last few years. And it is remarkable to see the amount of stigma and lack of understanding in hospital administrators and clinicians. But when we have the opportunity to talk to medical students, it's really a different picture. And so hopefully you know, as it becomes just normalized that addiction treatment is part of healthcare, then hopefully we'll see that that change happens.
That's so great, Cara. Thank you. And I share that hope for that next generation. I will say that to emphasize Gresha's point, though, the old dogs can learn new tricks in this space. And that's why it's really fun doing the addiction education and that your willingness, Gresha, to come to events like this and talk to folks. Cara, the wonderful work you do across the country to help increase provider education. I did want to just pull some things from the chat quick. Ginger, this is weird coming from me, but I did want to say it, Gresha, in case you didn't see it, that you're a beautiful person and you did a wonderful job. And thank you for sharing your experience here. This is kind of for Gresha, but also for Cara, about giving opioids during labor without providing alternatives and some of your experience with that.
Oh, my first 2 pregnancies when I was using, they prescribed the opiates just to keep me from withdrawing, or what do they call it, Cara? Baby withdrawal.
Neonatal abstinence syndrome or neonatal opioid withdrawal syndrome.
Yeah. I'm sorry, what was the question?
Oh, just about giving it during labor or delivery to make sure that, you know, they were talking to you about your prior experience with opioids and whether or not providers did, in fact, like consult with you, or they just like gave you the opioids and said, here we go.
They gave me the opioids and said, here we go. I mean, she prescribed them during the pregnancy and she refilled it right before I went into labor. So yeah, of course I was taking it during labor and delivery. But thankfully all 3 of my children are happy and healthy.
It's great, Gresha. Thank you.
That's something I always regret. So I'm
thank you, Gresha. Cara, I don't know if you could talk a little bit about maybe the best practices for having those conversations around labor and delivery in particular, and talking with people with lived experience or who use drugs prior to maybe doing that. Like Gresha said, being part of the conversation is good.
Yeah, with people who are on medication for an opioid use disorder, we can still provide them with opioids during labor and delivery. The trick is they already have opioids present, so the dose that we often give to other people just may not be effective. We talk about it in the clinic beforehand. We've worked closely with we're very lucky. We have I'm obnoxious because I'm in Grand Rapids, right? So we actually have a perinatal specialist anesthesiologist, which I know I'm talking to rural groups and you're like, ha, right, of course you do. But we were able to work with them on a protocol that has more of kind of the other types of numbing medications in the epidural. And so we have like an opioid avoiding process that we can try for patients if they so choose. Again, it goes back to respecting the power of the opioids. I tell people sometimes there's like, if I'm in a car accident and my femur is sticking out of my thigh, please provide me with opioids, because there is probably nothing that is powerful enough to address femur sticking out of thigh pain than opioids. And same thing for my patients with a history of or an active substance use disorder. But let's have those kind, caring conversations beforehand. Labor and delivery often takes a long time. It is painful. We're not going to lie to our patients. There are things that we can do to reduce the pain. We're not going to get rid of your pain. We should be having this conversation whether or not somebody has a substance use disorder, right? So really putting it into that frame. Absolutely, if you want to try an opioid sparing approach, we can absolutely support that in the hospital. However, we don't know exactly what's going to happen with your labor. And if something changes, I want the patient to know that you are the one in control of this. If we do start opioids during your labor, or if you have, a big tear or a a big tear or a C-section, then we may need to use opioids to address that pain. We're going to do it in carefully. When you are discharged from the hospital, our protocol is set up that nobody, whether they have a history of a substance use disorder or not, who's discharged post C-section receives more than 3 days of opioid medication, because at that point, if we're talking about somebody who had a C-section and has been in the hospital for postpartum for observation with rooming for neonatal opioid withdrawal syndrome, that means they were in the hospital for 5 days and they had 3 more days of opioids on discharge. So that's 8 days total course. If they're still having really significant pain, they may need to be seen by their obstetrician, right? In order to assess for some sort of complication of the pregnancy, of that delivery, that there's retained placenta, there's something wrong, there's the surgery site has separated. I don't know, right? Like there's a whole bunch of things that could happen. So that's part of the conversation we're having, right? Is we want to keep you safe in this postpartum period, and we don't want to give you more medication than you need, but we want to make sure we're addressing your pain. And then I tell them the most important thing you can do, because this is what my surgeon colleagues have told me across the board. This is the most important thing you can do. I want you to get up and walk as soon as they let you after your surgery. So I don't mean walking to the bathroom like hobbling around. I want you hobbling around doing a lap around the nurse's station as soon as they ask you if you want to walk. Because what we want to do is, I mean, this is not totally sciencey, but it makes sense to people, is we want to get the blood flowing and get some of those like inflammation stuff and some of the junk that's kind of at the surgical site, get it moving out of there. And the best way to do that is to get you up and walking postpartum. And the patients that we've had that do get up and walk need less opioids. So let's try to, and because their pain is less. So why would we not want to get up and walk if that's the best way to reduce our pain? Said from a walking treadmill desk. So we're not going to talk about that part of my life.
Yeah. Cara, thank you so much. Jen and Amanda, thank you for having us on today. Sorry we went 1 minute over, but thank you for everybody for attending. It's been a wonderful conversation. Gresha, really appreciate your vulnerability and that you made time and space today to share your experience with this audience. So thank you. I know there's a lot of people putting that in the chat for you too, Gresha, but we really appreciate you coming here, and congrats on your recovery. Cara, as always, wonderful to see you. Jen, I don't know if you have anything to do at the end. Oh, there's evaluation links. But thanks, everyone. This has been great.
Thank you so much for coming and talking with us. We appreciate all the knowledge and experience y'all all shared, Cara, Jonathan, and Gresha. If you have a chance, please fill out the evaluation form. I keep on putting it in the chat just in case. This training and will be provided, and a toolkit will also be provided on the website later. And please let me know if y'all have any questions. Thank you so much. I think that's it. Paige, can you stop recording?